Hi, so we'll be moving on to Chapter 2 in this lecture. We might also cover Chapter 3 in this video as well. So drug forms is the first slide I'm going to start talking on, slide 4 in the Chapter 2 PowerPoint presentation. Drugs come in various dosage forms. The physical and chemical properties of a drug usually determine what form will be most effective. Some common dosage forms of medications include tablets, capsules, syrups, and injectables. There's also suppositories, ointments, creams, transdermal patches. There's all kinds of different ways that we can get a drug into someone's body. It's just a matter of what's going to work best for them and how the drug is going to work best. So drugs can enter the body in several different ways. The most common ones you'll hear referred to are enteral, E-N-T-E-R-A-L, which is oral, and everything else is parenteral, P-A-R-E-N-T-E-R-A-L, and that can be anything that doesn't go through the mouth and the GI system. We talked a little bit already about absorption, distribution, metabolism, and excretion. So ADME, the process, the way the drug moves through the body. Absorption is the entrance of the drug into the bloodstream once it's been absorbed from the stomach or from the skin. Absorption can happen through filtration, passive or active transport, and lipid solubility, drug ionization, and drug formulation are properties that affect absorption. Distribution is the movement of the drug to various parts of the body, whether it be tissues or organs. So the drug is distributed throughout the body, or maybe it's only distributed to a small area. So several factors that influence the distribution include plasma protein binding, blood flow, and specific tissue barriers. So if the drug is highly bound to plasma proteins, it won't be distributed that much. And in addition, if the blood flow is very slow to an area, you're going to have a harder time getting the drug to that area as well. Metabolism is the biotransformation or chemical alteration of the drug in the body. The liver is the main organism that is involved in metabolism, and there is a system of drugs called cytochrome P450. A system of enzymes called cytochrome P450 enzymes that break these drugs down. So enzyme induction or inhibition can play a role in how fast or slow drugs are metabolized, and that can be influenced by drug interactions, how healthy someone's liver is, etc. So if someone's got a liver that's not working as well, we may have to adjust their dose based on what we know about how the drug is metabolized. Excretion is the removal of drugs from the body. The main routes of excretion are renal, which are kidneys, gastrointestinal, and respiratory. We worry about someone's kidneys just like we worry about their liver. We may have to adjust the dose depending on how healthy this person's kidneys are. Because if they can't get rid of the drug starts to accumulate and can cause toxicities. So on slide 7, we talk about half-life. Half-life is the amount of time it takes for the blood concentration to drop by half of the original amount. And we want to be able to tell how much drug is left in the body so that we know maybe when to dose the drug again. Okay, so we can determine if after one half-life 50% of the drug is left, after 2 half-lives 25%, so on and so forth. That number keeps getting cut in half. After about 5 half-lives, the drug is completely eliminated from the body. So blood drug levels. The intensity of a drug effect is determined mainly by the concentration of the drug in the blood. Loading doses are given to rapidly attain therapeutic levels, and then maintenance doses are smaller doses that are given at a certain set of time intervals to continue those therapeutic levels. Bioavailability is the amount of drug that is absorbed into the bloodstream. Orally, you might get anywhere from no bioavailability all the way up to close to 100%. It depends on the formulation of the drug, whether it can get absorbed into the bloodstream. Oral vancomycin is one of those drugs that cannot be absorbed from the stomach. So that bioavailability is 0. When we give it into the bloodstream, however, the bioavailability is 100%, and that drug is available to be distributed all over the body. Anytime you put a drug directly into a vein, bioavailability is 100%. Everything else, any other route of administration, is going to vary. So there are several factors that influence bioavailability. We already talked about route of administration. Anything that influences GI absorption or gastrointestinal absorption can also influence bioavailability. So factors of individual variation on slide 9. These factors will affect how a drug works in the body, how old the person is, how big they are, female or male, genetic variation, what kind of emotional state they're in, are they under stress, are there other diseases going on at the same time, what we call comorbidities, and how compliant the patient is with taking their medication. So, young kids, pediatric considerations on slide 10. Medications taken by pregnant women may pass into the fetus, which is why there's something called pregnancy categories to determine how safe the medication is to use during pregnancy. Some drugs can cause birth defects in an unborn fetus, so that's why we have those categories to let us know, yes, it's safe, no, it's not, absolutely not, could be risky, etc. Drugs can also pass through breast milk into infants, so we have to be careful if a mom is breastfeeding. Same with pregnancy. Not as strict, but still up there in the concern level. So because of the higher body water percentage and lower fat content, infants have a decrease in distribution of lipid-soluble medications, which causes an increase in blood drug levels. The drug just doesn't leave the blood. They also have an increase in distribution of water-soluble drugs, which leads to a decrease in blood drug levels. So lipid-soluble drugs are going to be increased, causing toxicities. Water-soluble drugs are going to be decreased in the blood, so they might not work as well. Drug dosages for pediatric patients or infants are calculated and adjusted based on body weight, surface area, and patient age. So we might take all those factors into account when we are coming up with a dose for a kid. So FDA pregnancy categories on page 13, slide 11. You'll want to become familiar with those because you will be including those in your drug information sheet. There's A, B, C, D, and X. Although I see one more there, I just want to enlarge that, A, B, C, D, X. And R is not rated. We don't really have any of those. If they don't know something, they're going to put it in a more dangerous category. And this is all based off of studies that have been done that show risk. However, doing studies in pregnant women is not ethical at all. So mostly what we have is information that comes from women who have taken these drugs either by choice or out of necessity, when the risk might be worse than the benefit, or the vice versa. So A is safe, B is maybe safe, C is probably not, D is definitely not, and X is do not by any means take this drug, otherwise your baby probably will have deformities. Okay, so drug interactions. Let me just get back to that. Drug interactions refer to one drug affecting the actions of another drug. And there are several types of drug interactions: incompatibility, additive effects, summation, synergism, and antagonism. Refer to table 2.5 for definitions. I'm not going to go into them now because you can just as easily read just as I can spout information out. Just become familiar with what they mean and what it means for a drug interaction, because drug interactions can be beneficial sometimes, and most times they can be harmful or unwanted. Last but not least, tolerance and dependence, a huge problem in today's society, especially with controlled substances. Tolerance means decreased drug effect with repeated administration. You may require higher doses to achieve the exact same effect that you had at a lower dose. There are two main types of tolerance: metabolic and pharmacodynamic. And dependence, which is reliance on a drug that becomes ever more vital to the well-being of the patient. If the patient doesn't have the drug, they will go into withdrawal. Tolerance and dependence are two separate things, so just keep that in mind. So there are two types of dependence: physical and psychological. Physical dependence, meaning if we take that drug away, we're going to put that patient into withdrawal, which might include tremors or seizures or sweat, hypotension, etc. It could be a range of different things that happen depending on the drug that they're addicted to. Psychological is a mindset. So the patient feels like they cannot survive without the drug. This is mostly, again, a problem with controlled medications, your pain medications, your sleeping medications. That's where tolerance and dependence develop the most. Moving on to chapter 3. Actually, we're going to do that in a separate video because we're already at 10 minutes. So there will be at least three separate videos. I'm probably not going to do too much on chapter 4, because math is really hard to teach by video. So I'll get to that at the end of chapter 3 video.